Good afternoon, folks. Now I'm going to try and do discussion A for you. Now, this afternoon's discussion A is discussing contingency and crisis standards for palliative care and hospice care. Okay, so that's what we're discussing today for A. Here we go. Contingency and crisis standards of care for palliative care and hospice services must prioritize continuity of symptom management, medication access, and goals of care alignment so seriously ill patients retain dignity and comfort when routine services are disrupted. Okay. Palliative care or palliative and hospice services are a moral imperative during disasters and system strain. Crisis standards must explicitly include measures to reduce suffering and preserve dignity while scarce resources are allocated. The Institute of Medicine framework and subsequent guidance emphasize that palliative care be integrated into crisis planning rather than treated as optional. Guiding principles: duty to care and fairness, balance individual comfort needs with population level resources, stewardship. Proportionately and transparency, contingency measures should be triggered by defined scarcity thresholds and publicity communicated. Continuity of goals, concordant care, preserve advanced care planning. Post advanced directive review and hospice transitions whenever possible. Operational components of contingency and crisis standards, triage and risk satisfaction, daily list, flag patients with recent medication titration, high opioid benzodiazepine, and needs an oxygen dependency, uncontrolled symptoms, or fragile caregivers. These patients receive prioritized in-person visits. Medication continuity protocols, pre-authorized emergency refills, standing orders for symptom control, and pharmacy coordination to prevent disruption or interruptions in opioid and other controlled drugs. Regulatory flexibility. Should be documented and time limited. Core clinician preservation. Deploy the most experienced palliative clinicians to cover high-risk patients rather than dispersing inexperienced temps across all cases. Telehealth and remote surveillance. Structured virtual check-ins for moderate risk patients with clear escalation pathways to in-person care. 24/7 palliative hotline staffed by senior clinicians to coach caregivers, authorize standing orders, and triage emergency department division when appropriate. Clinical protocols and quality safeguards, symptom bundles for pain, dysphagia, delirium, constipation, and nausea with clear titration algorithms and caregiver instructions reduce viability and risk. Documentation standards to ensure goals of care and medication plans travel with patient across settings. Safety monitoring for controlled substances. Short intervals, follow-up, caregiver verification, and pharmacy alerts to mitigate diversion while avoiding undertreatments. Communication, caregiver support, and equity. Provide one-page emergency care plans, brief video, coaching, and proactive outreach to caregivers. Prioritize language access and social detriment supports for vulnerable households. Legal, regulatory, and documentation considerations. Align contingency measures with CMS, hospice conditions, and state emergency orders. Document triggers, duration, and oversight to maintain regulatory compliance and public trust. Implementation check-in checklist. Activate triage list. Notify pharmacies. Stand up hotline. Redeploy core clinicians. Distribute caregiver kits. Log all diversions and interview and review daily. Conclusion. Contingency and crisis standards for palliative and hospice care must be proactive, ethically grounded, and operationally specific so that even underserved strain, the system prevents avoidable suffering and preserves patient-centered choices. Existing national templates and clinical guidelines provide practical tools to build these standards into emergency plans. The national consensus projects clinical practice guidelines for quality palliative care, define an interdisciplinary evidence-based framework organized into 8 domains that should govern clinical practice, quality measurement, and emergency planning for palliative and hospice services. These guidelines set expectations for structure, symptom management, psychosocial and spiritual care, cultural compliance and end-of-life care, and ethical processes, purpose and scope. Guidelines aim to improve access to high-quality palliative care for all people with serious illness, regardless of setting, diagnosis, prognosis, or age, and provide operational guidance for clinicians and organizations to integrate palliative principles across the care continuum. They were developed through systematic review and broad stockholder consensus and published as the 4th edition, 2018. The 8 domains: core structure and process of care, program organization, staffing, interdisciplinary roles, and quality improvement. Physical aspects of care, standardized assessment and management of pain and other symptoms, psychological and psychiatric aspects, screening and treatment of distress, depression, anxiety, social aspects, caregiver assessment, social supports, and community resources, spiritual, religious, and external aspects, spiritual screening, and chaplaincy integration, cultural aspects, culturally responsive care, and language access. Care of the patient nearing end of life, anticipatory planning, symptom bundles, and bereavement support, ethical and legal aspects, advanced care planning, decision-making frameworks, and documentation, key clinical expectations and operationalization, interdisciplinary teams, physicians, nurses, social workers, chaplains, pharmacists, and therapists must perform routine team rounds, use standardized assessment tools for pain, dysphagia, delirium, depression, caregiver burden, and document care plans with clear titration algorithms. Programs should embed these tools into EHR workflows templates for advanced directives and standing orders, symptom bundles to reduce variability and support safe handoffs. Quality measurement and improvement. The guidelines recommend selecting measurable process and outcome matrix. For example, symptom scores, timely advanced care documentation, readmission rates, and caregiver reported outcomes, and reviewing them regularly in quality meetings, continuous training and compliance assessment for both specialist and primary palliative clinicians are essential to sustain quality. Implementation priorities and practical steps. Adopt the guidelines formally and map current services to each domain to identify gaps. Prioritize quick wins. Standardize symptom bundles. A 24/7 palliative hotline, EHR advanced care templates, and caregiver education materials. Measure and report. A focused set of matrix monthly and use results to guide staffing, training, and reduce a resource allocation. Conclusion. The NCP Clinical Practice Guidelines for Quality Palliative Care, 4th edition, provide a practical, evidence-based blueprint for delivering person and family-centered palliative care across settings. Operationalizing the 8 domains through interdisciplinary teams, standardized assessments, EHR integration, and focused quality matrix. Translate the guidelines into measurable improvements in symptom control, care coordination, and dignity at the end of life. Okay, guys, that's your A. I will be back on shortly with B. Give me a bit for a little break, and I'll be back on with that for you. For now, Gator Wellness, take care, folks.